Today, I am presenting a very interesting case of RCA osteal bifurcation PCA with functional guidance. Our case is 60-year-old lady presented with exertional angina since 2 weeks, which was new onset and functional class 3 with no significant STT changes with good LV function. Presenting a very interesting case of RCA osteal bifurcation stenting with functional guidance. Our case is 60-year lady presented with exertional angina since 2 weeks, which was new onset and functional class 3 with no significant STT changes and good LV function. Here, angiogram was done elsewhere, which showed anomalous origin of large size LCX coming from the RCA ostium and also showed RCA. So we had to answer a couple of questions here, but because the however, we decided to do a CT-CAG because as it gives information beforehand and make plan about our strategy. CT-CAG was done on this patient, which showed common origin for both RCA and LCX, and both ostia has tight lesions and LCX originating after a tight lesion of RCA. We decided to do a provisional stenting. In case we are doing provisional stenting, our rescue strategy would be TAP versus T stenting because LCX originating at 90 degrees. So we choose Amplias guide and we decided to use provisional stenting strategy and we wide the both branches. It was a fibrotic lesion and RCA proximal lesion was pre-dilated with 2 and 2.5 mm balloons, and we didn't pre-dilate the LCX because once we pre-dilated the RCA, the flow into the LCX improved significantly because RCA ostial lesion extending before the origin of LCX ostium. RCA was stented with 3 into 18 mm stent while keeping the separate wire into the LCX. Then we post-dilated the RCA with 3.5 into 8 mm balloon. And once the stent was expanded and all, our next focus was shifted on to LCX, which has tight lesion. Even though the length of the lesion is very less, but it looks significant. How do you assess that lesion? Again, we had two options here, IVUS versus FFR. Whether we go ahead with the IVUS to do a plaque burden and then take a call or functional assessment. However, we decided to do a functional assessment because functional assessment is more accurate than anatomical assessment. Then we went ahead with FFR, which showed baseline value of 0.83 with the adenosine it was 0.64, which was significantly positive. Then we decided to do a kissing balloon inflation in RCA and LCX. We did kissing balloon inflation of 3.5 into 12 mm balloon in RCA and 2.2 into 12 mm balloon in LCX. Then once the kissing balloon inflation was done, we decided to do repeat FFR, which showed a baseline value of 1 and with adenosine it was 0.92, which was significantly negative. Here the final result, the stent is well expanded as well as TIMI-3 flow in LCX. Our take-home message is imaging helps in making a plan in complex cases. In our case, CT-CAG helped in planning the bifurcation stenting, and also physiological evaluation helps in decision making about sideband treatment in bifurcation lesions. Thank you.
Really a very good case. But why not upfront imaging rather than the CT-CAG and FFR? Because it is the lesion was quite significant. So why not upfront two-stent strategy was not planned. And regarding the circumflex origin, the plain balloon angioplasty, what is the role of DCP in such cases?
We did a depth to LCX because future complications of ISR is more
Yeah,
in
so
compared
in that
to
case, you have to use a DCB,
unlifted
drug-coated balloon rather than the plain balloon.
So you did
Yeah.
a plain balloon or a drug
Because
coated balloon?
circumference was
Drug-eluting
supplying
balloon.
a
No, they did
significant
a
rate.
drug eluting balloon.
Drug-eluting.
Drug-eluting.
Yeah,
Okay,
then it's good.
okay.
Then
it
it's
is
good.
okay.
Yeah. Nice case.
Yeah.